So the purpose of this webinar, so this demand and capacity modelling tool will focus on children and young people's mental health, as I've said, and this really is one part to support all services as you're developing your recovery and restoration plans in response to COVID-19. This webinar has been arranged to help all systems across the South East, and this applies to all providers of children's mental health services. So it's not just NHS providers, it can help voluntary sector, local authority, mental health support teams as well. So the aim of this webinar is to show you what the tool is designed to do and how you can use it with a few basic metrics, and David will help you, and hopefully you'll leave the webinar and feel confident to use it within your own services. It also will enable you to look at hypothetical scenarios within your system. So I now want to hand you over to David, if that's okay. I'm going to stop sharing.
Okay.
So welcome, David.
Thank you very much, Becky. Can you hear me, Becky? Save anybody else.
I can hear you loud and clear.
So let's assume everybody else can as well. And I'll share my screen now. So thank you for having me. What I'd like to do is just give you a quick run through some CREST type scenarios, give you a bit of a background to the tool and the sort of theoretical underpinning of it, which is sort of interesting, but you sort of don't need to know. And then show you through some simple scenarios that we've worked up to give you an idea how the tool might work and how the tool might help you make your decisions locally. And then after that, I'll have time for plenty of questions and a conversation, I hope. So I'm gonna start presenting. So this is a slide set rather than the model itself, and I've got the model open and I'll show you it in a minute. So CREST, oops, didn't expect that. Excuse me. So this is the outline. CREST is a demand and capacity tool developed for children and young people's mental health and was launched this year slightly earlier than planned in response to the pandemic. From my point of view, we were just finalising the tool when the lockdown came. The people that commissioned the tool, the NHS England and Improvement, immediately saw a role for the tool in COVID recovery for children and young people's mental health services. So we had a not quite finished tool that we quickly had to operationalise. And so there's still a few rough edges on the tool that we're addressing over the next week or two, because we had to abandon the development work to do some delivery work. And our developers also ended up doing a load of other COVID work around the returning GPs program. Anyway, so there are a couple of rough edges in this. Got potential uses across the mental health, learning disabilities, autism sector. And we've got some COVID specific scenarios at the CREST website, which we can look at. So the sorts of questions that CREST can help you with: how might I manage reduced capacity in my team because of absence, sickness, people self-isolating or shielding? You probably haven't got the resources necessarily that you'd usually have at the moment. How can you manage an influx of demand? Is COVID going to cause you less business? Probably in the short term, but quite likely going to cause you more business going forward. And if you're thinking about inpatient provision, this tool will help you with the number of inpatient beds you need to commission in order to meet your local demand. And this is all based on some fairly straightforward and simple data. You only need 2 or 3 actual numbers to start your modelling. Behind it is something called queuing theory, and that's a mathematical study of waiting lines or queues. And it's Erlang maths, because Erlang is the Swedish chap that came up with the maths that looks at queues and analyzes queues and enables you to manage queues and waiting lists. And it gets used in, so the examples here are call centers or telephone exchanges. I sort of think a handy example maybe to think about is when you go to the post office and they've got 12 counters open and you're in a great big long queue, And actually, it doesn't take you very long to get to the front of that queue and to get served. And the post office know exactly how many counters they need open to make sure that people don't wait longer than 5 minutes or 10 minutes, whatever their acceptable waiting time is. And they'll open and close counters through the day if the queue builds up. And the reason they know how many counters to open and when to open and close them is because they've modeled their queue using Erlang. What some bright spark a few years ago realized was that these Erlang principles and Erlang mathematics could equally apply to queues and waiting lists in healthcare. And this got particularly commissioned for children and young people's mental health. So here's some stuff on the screen in front of you is input known measured values. This is the basics of Erlang. How many calls per hour, how long on each call, how many people have you got available to take calls. You put that through an Erlang mathematics mangle and it gives you some key metrics. We're doing it with health, a healthcare setting, and we're looking at number of referrals per week, number of points of contact in a completed pathway. So a young person gets referred, they get accepted into the service, and they're then on the service pathway or a therapeutic pathway, and you might see a young person 8 times. You might see another young person 5 times, and they've completed their pathway. So that's the points of contact. How long do people stay in the service? How many appointments do they have? You put those things and the number of available appointments you've got to offer to young people, and you put those things in, and it tells you about how likely you are to wait an excessive period of time and how many appointments you're likely to utilize. And I'll talk a bit more about those things later. Now, I think those last 2 slides are about as complicated as it gets. The mathematics that delivers the results we're going to see in a minute is very complicated indeed. And it took me a long time to sort of actually grasp what it was doing and to understand it. And what I realized when I did understand it was, well, I didn't really need to understand why it was doing what it was doing. The results sort of speak for themselves. So there's lots more you can find out about queuing theory and how it works and how it's been applied in all sorts of different scenarios, and you can get quite interested in the different maths, different mathematical approaches. But actually what we're interested in is delivering sustainable, manageable services in children and young people's mental health. So you've got some stuff there if you want to take an interest in Erlang maths that you can refer back to and go and explore elsewhere, but that's as much as you really is as much as you need to know, if not slightly more than you need to know. So cool, we'll press on. So a brief example exploring how to manage increased demand as a result of COVID-19. And this is one that we've sort of cooked up to help guide people through how the thing works. So it's a hypothetical scenario, and we've got a small third sector counselling service, which prior to COVID was accepting 250 referrals per year, approximately 4.8 accepted referrals per week. So that's the demand, 250 a year, and they're coming in somewhere around 4 or 5 a week. The therapeutic sessions delivered at a number of locations, face to face. So sometimes at someone's home, sometimes at school, sometimes at a clinic. And they did a little bit of the therapy being delivered online via a Skype or a Zoom or something similar to that. Their average treatment was 6.3 sessions per person. So that includes all the children and young people you only saw once, all the ones you only saw twice, 3 times, 4 times, 5 times. Some you might have seen 15 times on this pathway, but on average 6.3 sessions per person. And just to note that this average includes the service DNA rate. And we've got some stuff on the website on how to include your DNAs. But what you're wanting to do is say, how many appointments do we need to make available each week to manage the flow of patients through? And so we need to include a DNA rate in that, because you've made that appointment available. It's just someone hasn't turned up for it. So you only really include the DNAs that happen so late in the day that you're unable to repurpose the appointment. But there you go. The service is currently set up to deliver 35 appointments per week, and their contract, they've been commissioned on the basis that when a young person is referred into that service, 85% of them will be seen within 28 days of their referral. So that's a sort of performance metric. So 250 referrals per year is the demand. A combination of the 6.3 sessions on average for each of those. The service resource is 35 appointments per week, and the service standard is those patients come through, 85% of them want to be seen. We want them seen within 28 days. In fact, the provider will be breaching their contract if they don't. So you can now, on the screen now is a grab from the website, from the web tool itself, and I will go and do some live demonstrations once we've been through those slides. So you get a screen to enter your key bits of data. We know the service was set up based on 35 appointments per week, and we've put a range in 35 to 50, which you'll see in a minute will come out on the graph below. The average referrals per year are 250, and that comes out at 4.8 cases per week. The average points of contact per accepted referral, remember including a 10% DNA rate here, 6.3. The waiting limit in days, 28. And the proportion you want to see within that 28 days, 85. So really, we've had to know about the 250 average referrals per year, and we've had to sort of work out from those 250 referrals per year, what's the average number of contacts on a completed pathway. And really, those are the only two numbers that you need to be able to run this model. If we plug those numbers in to the model, like so. Oops, sorry, I haven't looked at these slides for a while. So there's the baseline. There's the how it was set up pre-COVID. The onset of COVID-19 has driven an increase in referrals, and the service is now accepting approximately 6 referrals per week more. No, it's now accepting 6 referrals per week instead of its 4.8. Approximately 310 accepted referrals per year. More of the therapy sessions are being delivered digitally than prior to COVID. So in our test values, we've entered 310. Let's see what this gives us. By placing this increased activity into the model, it becomes apparent that to manage this new demand, the service needs 40 appointments per week. And it had 35, started off with 35, which you can see at the far left, marked baseline. But that increased demand from 4.8 referrals a week to 6 referrals a week, if you're going to meet and see 85% of referrals within 28 days, you're going to need to provide an extra 5 appointments a week. And the red line here is the percentage which will breach your wait time threshold. So the wait time threshold is the purple line. It's 85%, so it's there at 15% because you want to get the numbers breaching down below 15%, because then that means the numbers being seen within the wait limit is above 85%. So you're looking for where this red line drops below the breach limit. It's as simple as that. And that tells you 40 appointments. If you offer 40 appointments a week, those new referrals and your existing referrals will flow through, and you'll still be able to see 85% of them within 28 days. The blue line, the sort of bluey green line, it's dropping down as well, is the average waiting time on that one. And that's coming down at that 40 appointments, around about 10 or 11 days average wait time. And that's against a 28-day wait limit. So by increasing from 35 to 40 appointments per week, you should be able to continue to see all those children and young people, even though you've got more of them, all within 28 days. The blue line at the top is your utilization. So you're not going to use 100% of those appointments, but what the the ones you're not utilizing or doing is they're your headroom for when it gets really busy. Because although you've got an average of 6 referrals per week, it'll be very unusual if you had 6 every week. And actually what happens is some weeks you'll only have 3 referrals, other weeks you might have 12. So what the utilization bit is you don't use all those appointments because you want to be sure you're going to see everybody within time. And the cost of meeting that wait time standard is that some of the appointments aren't going to be used. So you need slightly more appointments than you're going to use in order to guarantee the wait time standard. And that's the trade-off. So the service lead has done this little bit of modeling. They've modeled their increased demand, and then they have a conversation with the service director, and together they consider the other impacts of COVID-19. What becomes clear to them once they have a conversation around this is that there have been some real productivity benefits in delivering more of the therapy digitally. So one of the things they've been doing is doing more stuff online because of social distancing and all the rest of it. They've got positive feedback from the people who are receiving their therapy or counselling sessions remotely. People like it, and they're happy with it. The people delivering online therapy and counselling, they sort of quite like it as well because they've got more time for doing things like clinical notes and for professional liaison relating to cases because they're not travelling around from appointment to appointment. Should be a reduced cost for the organisation as well. And most notably, the DNA rate reduced significantly, which means treatment is now on an average of 6 sessions per person. It was previously 6.3. So by switching by necessity because of COVID-19 to a sort of online delivery, they're finding people are less likely to miss their appointments and not turn up. So we've got to feed that back into the model. So what we do now, we were saying, well, we need an average of 6.3 contacts per accepted referral. Well, now we're working in this sort of COVID world and we're doing stuff online. Actually, we're not doing 6.3. We're probably only doing 6 per completed pathway. So by placing the amended average sessions figure into the model, it shows that because of the reduction in the DNA rate, instead of needing an extra 5 appointments from the baseline to 40, actually, we only need another 3 appointments to get that blue line, it's a red line, the red line dropping underneath the wait time threshold. So by adjusting that average number of contacts, taking account of a reduction in the DNA rate, we can see that an additional 3 appointments a week on top of the 35 will enable us to see all those extra children and young people. This is one of the things I think that's revealing about this this approach is look at the difference. You're right up at 100% missing. None of the children and young people are going to meet the wait time standard if you stick with 35 appointments. They're all going to be waiting longer than 28 days. And their actual wait time on the blue line is sort of shot up to infinity, but it's going to be pretty much indefinite. It'd be difficult for you to say with confidence how long someone was going to wait. But just by levering in an additional 3 appointments, you can bring that system and that queue and that waiting list back into balance and make it sustainable again. So it's not the case to halve your waiting time. You need to double your resources. In fact, it's nowhere near. And what this maths, I think, is one of the really revealing and useful things about this maths is you may feel you've got a nightmare waiting list challenge. You're just seeing the next one that as soon as there's a therapy slot available, you pull the next one off the waiting list. You've never done any of this maths. It's on a block contract, who knows? And people are waiting ages and ages and ages, and it can look like a real huge challenge to bring that back into balance in terms of resources. Whereas actually, a small increment in resources can produce a big change in terms of how long people are waiting from their referral to their first meaningful contact. So here we are, we've taken account of a reduced DNA rate, and that's had an impact on the resources we need. We need just 3 more to meet that extra demand. The counselling service share their findings with their commissioners, and they start thinking about, given the unprecedented pressures on the system, should they relax their wait time standard? And instead of looking for 85% of all children and young people referred, getting into therapy within 28 days, they start to think, well, could we live with just 75% of our patients being seen within 28 days, and 25% of them waiting a bit longer than that? So then we model that out, we adjust the breach target. So I want to see that thing at the bottom there. It used to say 85, it now says 75. 3/4 of my patients within 28 days, please. And the modelling shows by changing the breach level, this could in fact further reduce the number of additional appointments the service needs to provide to just 2. So if we're happy to reduce the wait time standard a bit, we only need 2 additional appointments a week to manage that additional demand. Be an average wait time of 26.4 days. Appointments would be 96.7% utilised up there. So on with the story. The commissioners and service leads used the modelling to discuss and agree the optimum number of appointments to commission. The modelling helped all the stakeholders to see the impact of any change to the waiting time target, and none wanted to alter it, as it was felt a key metric in ensuring those that need support can get access promptly. Given the increased percentage of sessions being delivered digitally and the subsequent reduction in travel time, the service agreed that they can deliver 38 appointments per week, 3 more than prior to COVID-19, without having to increase staffing levels. So the reduction in DNA and the improved efficiency, which comes from people working from home and online rather than whizzing around in cars and on their bikes, means that they've levered in additional capacity. So the final position would mean an average wait time. So they're going to keep the 85% threshold. This will mean an average wait, and they're going to keep 38 appointments. So an average wait time of 11.7 days, and the appointments will be 94.1% utilised. That's where it ended up. So they ended up agreeing an extra 3 appointments and maintaining their wait time standard. Taking the reduction in DNA into account, they're able to deliver that within their resources. That puts us there. 14% will breach, and we were looking for anything under 15%, and there you are, your average wait in days of 11.7. So as shown, to get started with CREST, you only need 3 key figures. And actually, if you're modeling a new service, you can anticipate those figures. If you're starting to think about, you're going to bring 3 services together under one banner next year, then you can do this in a fairly speculative way and start thinking about, well, we don't know what the average time on the pathway is going to be, but what do we think it's going to be? If we use a Thrive model, there's some guidance there about how many appointments on different levels of Thrive pathways. Things you can play those into your modeling. You can do a best guess, and that'll give you something to start talking around about, or you can use some actual figures you've derived from your actual data and the actual work you've done. So those 3 key figures: the average number of accepted referrals for the service or unit in a period. We're looking at a year. Works best, we find. Number of available appointments in the service, and we're generally doing that weekly. And then the average number of appointments each accepted referral will receive during treatment, or the average length of stay if we're talking about a hospital bed, inpatient setting. The tool is available to anyone in the UK working in health or social care, and you can register and access the tool instantly on the website. The web link's there, and I'll make sure Becky's got these slides so that she can circulate them to you. And if you go to the website and register and log on, there's a bunch of other scenarios sat at the website. We've got a support team, which I'm part of. And you can email through and we can get back to you with some tips and tricks, or join up on Skype with you for half an hour and help you through your modelling and talk things through. If you've got an NHS Net account, you can just log straight into the tool with your NHS Net account if you're working in a local authority or the third sector. As long as you've got a UK IP address, the registration process is really quick. You know, and you use your email and a secret password that only you know to get in and out of the tool. So,
David,
yeah.
I've got a few questions. Is it okay
Cool.
if I just ask them just at this point?
Yeah, whatever's best for everyone, yeah.
Ray Percy has asked the question, does the maths tell us anything about the lag between increasing the number of available appointments and waiting times coming back in line with targets?
No, not immediately it doesn't, no. You'd have to sort of work that out again. Yeah, I mean, it should flow through within the 28 days. So I think after the first 28 days, it should then, you'd think that it would then have mainstreamed itself with the new set of appointments and the new length of pathway. So I think it must sort of shade through over a period, probably the duration of your wait time limit. But I've not been asked that question before. It's unusual to come on and get asked a completely new question. So I haven't got a ready baked answer for that. And I'll think about if there's a more useful answer I can give.
Yeah, we'll make a note of these questions, and then we can always expand and come back to you, Ray. Yeah. And I guess Nick Gitcham has also asked the question, does the model assume no backlog?
It does assume no backlog, yeah. So you have to create a backlog and create a model for your backlog. So it does assume no backlog. It assumes that's your sort of steady state. And what the model's trying to do is tell you what your steady state is and what is a sustainable pathway. Then you need to think about, is there a backlog issue? How quickly do I want to clear the backlog? And the tool enables you, or is going. At the moment, we're working on a module which will do the backlog for you. But basically, if you have a backlog, then the approach is to annualize it. So to figure out if you've got a backlog, a 3-month backlog, and that's got 100 young people in it, then actually that's 400 through the year. And then you model the 400, and then that tells you how many appointments you need to manage your backlog. And then you add those to your steady state appointments, and you should start addressing your backlog then alongside your mainstream work. But we are bringing a backlog calculator into the thing so that you can put your referrals in, and then your backlog, and then how quickly you want to clear your backlog. Because again, that's an issue as well. If you want to clear a backlog fast, you need more appointments. If you could clear your backlog over a longer period of time, you need fewer appointments. So we're developing a tool that will do some of that automatically for you. And that should be sat there in the next 3 or 4 weeks, we think. But in the meantime, it's a matter of figuring out how big your backlog is, annualizing it somehow, and then modeling that number to give you the additional bit you need to clear your backlog.
Okay, thank you. So there's a few more questions coming in. Ray has said, and Ray, do come on if I'm not saying it in quite the right way. So Ray's thanked you for your original answer, and he said he was just wondering whether you have to wait a full 12 months for it all to come out in the wash as it was. So given the model is based on number of referrals per annum.
No, I don't think so. I think you could see quite quickly whether or not it was delivering what it should be delivering. So within a month. I'm going to have to think about these questions, Ray. They're good questions. And actually, you know, I'm sure the maths will do it. I'm not the maths geek with this, unfortunately. We've got someone who actually knows maths, who sort of set this all up in the background for me. And that's certainly something I'll talk to them about, because it does seem that you could put an extra parameter in an equation and it would start to give you that clear information. Well, the answer is, Ray, I actually don't know, I'm afraid. I do know it's a really good question, and I'd like to know the answer, and I'm going to find it out.
Okay, thank you. Thanks, David. And good that you've given a good question, Ray, to get David thinking. So, Dave West, you've asked a question. I don't know whether you want to ask it yourself rather than me asking. So do come on.
Hi, yeah, thank you. No, I'm just trying to, we've done some modeling like this before, not this sophisticated, but what we find is that we can model the up to the first assessment, but the the impact on the whole of the team depends on whether or not you put your attention at the first assessment slot in terms of your capacity, and if you focus your attention there, of course, you then create a backlog further on down the pathway in terms of your treatment slots. And how you can focus on that part of the model depends on your existing caseload. I think my question is a little bit similar to one earlier, which is how you take account of your existing caseload. We've got, I think, 20,000 patients on our caseload at the moment. So the point at which they're in their pathway will impact, and the amount of contacts that they've had, and the sizes of the caseload then has an impact on the intensity of treatment that can be provided by the clinicians. And I guess this links to what you were mentioning in terms of the Thrive model. That then links to how quickly you can manage the throughput. Just trying to think about whether or not the model can be used to help us understand that.
I think so. It's modeling the whole pathway, not just, so the wait time is from referral to first appointment.
Yeah.
But the assumption is that first appointment is the first appointment in a pathway, and we're modeling the pathway. And in fact, what it's modeling, or what it's figuring out, is, are there enough pathways becoming free each week to pick up the new referrals? So that's the sort of question it's answering. Have you got sufficient appointments there? Because of your 35 appointments in that example, they only needed 4 or 5 a week coming free in order to start the next pathway with the next young person. So, and it's taken account of the fact that some people, so the maths takes account of the fact that some people only need 3 appointments or only have 3 appointments, whereas some people will have 13. And so the maths is saying, how many free pathways are opening up each week? And is that enough? Have I got enough appointments to ensure that someone's being discharged, enough people are being discharged each week for us to pick up the new referrals? And so if you get that bit right, the rest of it flows, and it sort of doesn't matter. Yeah. So that's how it's working. It is modeling the whole pathway. And what we usually would do if we were working closely with a provider or a commissioner is say, let's have a look at all the pathways in this service that ended in the last financial year and how many appointments were there on each pathway, and then get the average from that and use that to model forward. I'm not sure how far that answers your question. Your question had a few elements to it, and I'm not sure I quite grasped them all. But it is modeling the whole pathway. You can do just a referral model. So sometimes you have a single point of access, and actually it's really only a single appointment happens in that particular bit of the service. So there you have an average of 1, or maybe an average of 1.1 if you've got a DNA rate for that assessment. And then that tells you how many assessment appointments you need to have available to do your assessments. And then people are, I was going to say pushed, but it's not the right word, but you know what I mean, into different pathways, and each of those different pathways will have their own points of contact and their own demand, and so will have all their own needs for appointments. So you can do it either way, if you like. You can model to assessment and then the onward pathway, or model it all as a piece. But the essential thing, I think, or the way I like to imagine it, is what you're actually trying to make sure is you've got enough appointments so that there's always some free for the new people coming through the door.
Okay. I mean, in our services, we have an issue where we have commissioning targets to achieve an assessment, and then we also have commissioning targets to achieve a treatment. They're 2 separate targets. So if you focus on one, that has a detriment on the other. That's kind of like as you can imagine, if you clear your assessment contacts, you've then got
a load of demand to pick up, haven't you, in the treatment pathway. So in that we would model. Yeah, we would
Yeah.
model both pathways and say, well, what's the impact on your referral policy of these various treatment pathways?
But in order for the treatment pathway to be effective and for there to be effective patient flow, you've got that great big caseload that you've got to be able to manage the throughput
Yeah,
along, I guess. And
yeah,
that's the bit which I think would be really helpful if we could model that. So I was quite excited when you said that you would, in terms of clearing the backlog, I guess, is that the same thing as your existing caseload, I guess? There's people that you're not modeling coming in the front door.
yeah,
If we could have a way of modeling and understanding the throughput of that, looking at, as you said, looking at an analysis of the ended pathways,
yeah.
to give us an idea of, roughly how many contacts are people having, how long are they staying on the caseload, and then being able to think about, because
What you
need to be
need,
able
yeah,
what you
and then
need to be able
what resources would you then need? You know what the typical pathway looks like. You know what the typical experience is.
to,
Now you know that. How much resource do you need to make available in order to flow through your 20,000 or your 2,000 or your 500 or whatever it is on that pathway?
whatever it might be. Yeah.
Yeah.
Okay.
So that's exactly how this, is intended to work.
Okay.
I remember a really interesting conversation in working with a system, an STP, doing some of this modelling.
Mhm.
And this was around an urgent service, and the commissioner saying that anyone who gets referred into this service, we want them seen within 2 days. And then it was going to be quite an intense 9 or 10 appointments on the pathway. But the crucial thing one of the crucial things for the commissioner was 48-hour wait time. These are important. We need to get on them. We did the maths, and the utilization came out at about 60% for the appointments. So the number of appointments you needed to guarantee to see people within 48 hours was 40% higher than the number of appointments you're actually going to use, because you wanted to be sure you got it right on those busy weeks when you get 6 at once instead of just the 1 or 2 a week that you'd on average expect. So the provider was in the room and showed them this, and the provider immediately said, well, that's ridiculous. There's no way the commissioner is going to accept us having 40% of our appointments not utilised. The commissioner in the room said, well, actually, the most important thing for me is that those children and young people are seen promptly. So the 40% utilisation cost, I can the 60% utilisation or the 40% non-utilisation, I can think about as a cost of delivering that service standard. So, and I'll be expecting all the staff on that pathway to be really well trained and up to date, and all the notes to be up to date, because we know that part of their time is there in case. So it did open up a different sort of conversation between the commissioner and the provider. And it gets you thinking about the utilization and not constantly aiming for 99% utilization or even 95% utilization. What's important to you? Is it seeing those children and young people in time, or is it not spending a marginal amount of money? And it sort of sharpens that focus a little bit for what are you going to decide to do? And it just sort of helps you see the different dimensions to that, I think.
Thank you both.
Thank you.
Thank you. So there are a few more questions, but I wonder whether if we let you carry on with presenting the tool, and then I'll come back to Louise and Andrea, if that's okay.
Yeah, sure. So I'll just run through some, I'll pop onto the website and just do some ad hoc, or show you a couple of bits I've got there already, and people can see how it's done. Cool. I'll grab the screen then, Becky. Which one am I sharing? It's not that one. Right. So can everyone see Catherine Pugh? Anyway. So yes, you got my screen? Cool.
Yeah.
So this is the CREST website. CREST stands for Children and Young People's Mental Health Referral System Management Tool. So CREST is a bit of a made-up thing. It follows on from something called the System Dynamic Modeling Tool, which was sort of an earlier iteration of this. which was really useful and did the sort of same things, but it was a lot more difficult to get the data in, and a lot more work to get the results out. So so this is the home page, and it's got some information. It's a home page. There's an about bit. It's got stuff on the back. Oops. Background of CREST, theory behind CREST. So we find out about Erlang. What can I use CREST for? And then we've got a couple of examples: managing reduced capacity under COVID-19, or CREST support for developing COVID-19 services. There's some bits and pieces. There's a help and guidance section, user guides, frequently asked questions, glossary, and then back to those examples. So we actually model. Oh, that's handy. I thought I was logged in, so I can do the logging in bit. So Ray. So that's me. Connected organizations is something here that when you start modeling and start using this and start saving your models, this bit you'll be able to connect to other organizations. So if you're in a particular provider or a particular CCG or STP or whatever, then you can do something here and identify connected organizations and people who can come and look at your models at the CREST tool. So if you're working, across a variety of agencies, they can all join up here and all be working on the same models. And you create your models, and then they get saved in this area here, and you can pick them up later on. I'll just create a new scenario just for fun. And then you get your modeling checklist. And so trying to make this as easy as we can for people. Just a reminder of the information you need. I know my average referrals per year. I know my available appointment slots or beds, and I know the average number of appointments, average length of stay for each accepted referral. If you're not sure what you need, there's some guidance on the little blue here, but I'm ready, I think. And then service name, that's DC1. We're going to do a community service rather than an inpatient service. Those are pretty similar. And then click create. And then we're here where we can create the model. And there's my model, DC1 there. And it's already filled with some values. But I think I want to see my pathway's got sort of 370 average referrals per year. And we see them 7.4 times on average. So we've got 7.1 cases per week. They're on the pathway, 7.4 contacts. And actually, we don't want these particularly young people hanging around too long once we've identified them as needing treatment. And so I've ignored the available appointments per week because I don't actually know. So you don't need to know that, as you'll see in a second. But yeah, I know my 370 referrals per year. I know it's 7.4 points of contact per accepted referral. I know I want to get as many of them as I can in within 14 days, 95% please. So I'll put those in, run the model. And the model says you will need a minimum of 60 appointments a week to see 90% of your patients within 14 days. What these numbers do up here, the current values and test values for appointments, is they set the axis on this graph. So at the moment, the axis is set between 100 and 110, but actually 60 is what we're interested in. So I'm going to just adjust that to 55, 70, run it again. Then as we scroll down, actually it needed 60, put 55. Yeah, so there's at 55, and we're at 60 when we start to drop below the threshold line. So percentage of breaches, 3.3%. Utilization of 87.8, so it's quite an expensive way to meet that wait time threshold. it's got a cost. That's the cost of meeting that wait time threshold of 95% within 14 days, is you're not going to use all those appointments. But your average wait time, they're going to be in on average within 1.7 days. And if you can offer that 60 appointments a week, you should see 95% of those 370 cases through the year within the 14 days. And it really is as simple as that. And then for all your values here, you get all the calculated values out of the math. So you get a nice table with all the values on. And you can start to see, you know, how big an impact reducing or increasing by a single appointment will have. Not quite seeing it fall apart there, because we've got, I drop it to 50. Yeah. So if you went down as low as 52 appointments, your service would be unstable in terms of managing your waiting list. You'd have no hope at all. But actually get it up to 60 and you're meeting that quite stringent wait time standard. We can have a look at the impact of the wait time standard if sometimes. So let's say actually 28 days is plenty. It's fine. We don't mind them waiting 28 days. Doubling the wait time standard only gains you 3 appointments. So we needed 60 before. Now we do it in 57. So doubling the length of time people will wait doesn't have a huge impact on the amount of resources you need. Actually, once those children and young people are in the service, they need their 7.4 appointments on average. If you only wanted to see 85%, so really not a terrible, you know, not a particularly stringent wait time parameter, you're then down to 56 appointments per week. And so you assess your service, you get those key numbers for your service, either a service that you're already working with, that you're trying to improve the flow through of patients, make it more sustainable, or you're trying to bring some services together into a single service, or you're going to create a brand new service. You play around in here. I'm not sure that download, looks like download chart is working. So you can click download chart and get a quality PDF version of this graph. And at some point, a button's going to appear here for a download, and you'll drop an Excel spreadsheet of this data in there as well. So you can output those things and easily share them with colleagues. So there's an example of how you might go in and test your own services or test your own scenarios, and so you can adjust any of these values as you wish. Run model, see the curve. That raised up any questions? Is that helpful?
Thank you, David. So can I go to Louise, because she had a question previously, and just to see whether she would like to bring that in now.
Of course.
Hi, David.
Hi there.
I don't understand the maths at all, so I'm not suggesting that I do at all, but I just wondered whether variance from the mean in terms of your average appointment number has been accounted for in the model, because my understanding in terms of kind of flow theory is that variance from the mean is quite important. So if your variance is, I don't know, the difference between, if you say your average is 6, but it varies between 5.5 and 6.5, there's a difference in terms of the number of appointments that you might need if your average is 6, but it varies between 2.5 and 10.5.
Exactly, yeah. So what this is doing, it's using a standard distribution and calculating a notional standard deviation, and then using that standard deviation to work out how many children and young people are likely to be on the pathway. 1 standard deviation more than the mean, 2 standard deviations more than the mean. Does that make sense? Do you know about standard deviation?
Yep.
So it assumes a distribution, and that is an assumption. and then it assumes a distribution and it allocates all the referrals to that distribution, and then looks at the standard deviation and says, well, 5% of these, although we've got an average of 6, 5% of them are going to be more than 12 appointments. And so it works it out that way. There's another way of doing the modelling, which is a bit more complicated, where you actually input the actual standard deviation of your actual distribution of patients. So as I said, you look at last year's completed pathways and work out the average number of appointments. You could also work out the standard deviation of the average number of appointments. And you could have a slightly different model where you plug in the standard deviation for that particular distribution.
Okay.
When we tested the model, we found it made very little difference indeed, whether you used the standard distribution that's implied in this maths, or whether you use the full maths by introducing your own standard deviation. And we didn't find a case where it made a difference in the number of appointments. So you'd still end up on the same number of appointments, but your average wait times and your utilization and your breach proportions might be slightly different. So having tested it, we came to the view that using a standardized distribution and only asking people for the average was probably better than getting it slightly more accurate, but asking for quite a lot more from people in terms of, it's easy to explain the mean, pretty easy to explain the mean. If you then got to explain the standard deviation to a CCG, Children and Young People's Mental Health Commissioner, who don't think about these things ever from one year to the next, and then ask them to try and get that out of their BI support. When actually, if we just add the average, we can get nearly as accurate, and as accurate as makes no difference without it. So okay. Yeah, so you're absolutely right. You do need a measure of variance. We're using one that's generated by the maths itself rather than a real measure of variance. Okay. But having tested the alternatives, we reckon to make it easier, it's easier.
That's good enough.
Yeah.
Okay.
Does that answer your question?
Yeah, that's helpful. Thank you.
Thank you.
Okay, thank you. Andrea, are you still on the line? Andrea King had a question. She does have to go at 12, so she might not be on the line. Let me see.
Have you got her question, Becky? Because you could ask it. And,
I will ask her question. So does the model enable consideration of higher levels of need and risk in which some children and young people are a higher priority for prompt assessment?
You could do that, yeah. So you could say, we're expecting 800 children and young people to come through our pathway next year. We can work out the average number of appointments and we can say a 28-day wait time, but actually you know that of that 800, there's 100 of them that are going to have a lot more appointments, and that ideally you want to see a bit quicker than 28 days. So you'd run two separate models on that. You'd have to figure out for yourself the proportion that were high risk, particularly vulnerable, needed more immediate action. But once you had that 200 out of your 800, 100 out of your 800, then you'd model them with slightly different parameters. This 100 people, we want to see 100 of them within 7 days, not 28. We want to see 95% of them within 7 days. And they're going to have, because they're more vulnerable, more at risk, they're going to have 8.5 appointments, not 6.5. So you'd run a model for that cohort. And then that would tell you how many appointments you needed to manage that, to sustain the flow and manage out that high risk group. And then you would model your other 700, which are your standard, more mainstream patients. And then you could have, you say, we need X number of appointments for the tough ones and Y number of appointments for the more standard ones. And then X plus Y would be your total number of appointments you need. So you could do that. It won't tell you how many you've got that are particularly at risk. And there's nothing in there that will do that for you, but you'd need to do that bit for yourself. But once you knew what proportion you thought were particularly high risk or needed a particularly focused service or approach or response, then you can model that through, yeah.
Okay, thank you. That's really helpful. So can I go to Nick? It seems to be more a comment, but I don't know whether you want to expand on that, Nick Gitcham.
Hi, yeah, that was just based on the discussion that was happening at the time about
sorry.
waits for first appointment and then waits for treatment. It's often good to set a target for the percentage of waiting for the first appointment and then the percentage who are discharged within X weeks or months.
Yeah, and again, so you do an assessment or an assessment pathway with a single appointment in, and then you'd model the treatment pathways that flow from that and do them as two separate models. Is the usual approach we take to that.
Okay, that's really helpful, I think, for people to understand. Thank you. Thanks, Nick. So Gavin Lockhart has also apologised because he's had to go, and he's asked, I think, more on the chat for those attending this meeting, if any services have data yet on whether the length of input, number of sessions needed for children and young people has altered since the start of COVID or lockdown. So maybe if you can all add in any comments to that, that would be hugely helpful. Gavin is our clinical lead across the South East for children and young people's mental health, learning disability and autism. And he's recently, we've sent out a literature review in response to COVID, looking at the impact on children and young people and predicted numbers and percentage likely increase. So yes, if anybody hasn't received that literature review, do let me know. Dan, we'll come back to that question if that's okay. So Gal, you've asked a question. Do you want to maybe expand on that? That's okay.
Yeah, it's fine. Hi, David.
I know.
My question is, so I think it's been great so far, and I'm not that techie, but I kind of get some of it. My question is around resource in terms of this modelling. I can see that you model it and you say that, so here's your service model, the number of appointments you need. But I wondered if there was anything that would then tell you what resource you needed to manage that service, or if that is something completely separate or something that was planned. Because as you change your service model, your resource requirements might change.
Indeed. So so the previous version of this, the SDMT, had what I call a costing model on the back of it. And then depending on how you define the service, so which one of the Thrive levels, so you might pick one of the Thrive levels, then that would automatically attach a cost per appointment to it. And it was broken down by psychiatrists, psychologists, nurses, etc. What we found with that was no one liked it, because every provider and every commissioner we ever worked on it with said those aren't our costs. And they were based on some national costing. They were really good because you could run a curve of cost. So we've just got utilization and wait time and breaches. You could also run a cost curve. And so it was quite useful because you didn't always need to double your cost in order to improve your service. But we found it was just too controversial, that no one liked the numbers and it didn't fit with anybody. So we pruned it back to say, this is how many appointments we think you'll need. And you can imagine a model, I think, when it comes out and says you need 37 appointments a week.
Yeah.
That's not one whole-time equivalent. That's the issue for the provider and the commissioner to talk about. How are you going to deliver those 37 appointments a week? Because you can't do it with one person, because they've got to do all the writing up, they've got to do notes, they've got to eat, sleep, breathe. This is a reflective business, all that sort of thing. So on each pathway, if you've got to deliver 37 appointments, there's a calculation about how many people is that. How many appointments on this particular pathway can a therapist safely manage? And then you start working out your resources from that. So it just added too many complications in terms of how you do it to deliver something that didn't satisfy anybody. And so we've sort of drawn back from that a bit, because every service is so different and every area organizes its services in different ways, and that having a generic one on there was more problematic than it was worth. So we've taken that off. But we're aware it's something.
Yeah.
We're aware
that's
it's something.
Fine, thanks.
Okay.
Thanks. I used to, so I've worked in call centres in the past. That was my background. So we did a lot of this, but we also had a resource model. So we could just put all the figures in and it would tell me at any time in the day how much resource I needed. But yeah, so I've done a bit of it before. But yeah, thanks very much. That was good.
In this world, that sort of thing happens when you do a full CAPA model of your services. So some children and young people's mental health services do the CAPA thing, where you look at every member of staff and what their availability is and what they can pick up and what they can't pick up, and you use it both as a sort of strategic planning tool, what you're going to do next year and the year after, but it also boils down to a rostering tool as well. And so you can see for any day of the week where your pinch points are, where you might need to lever in some overtime from somebody to cover someone else who's off, all that. And these sorts of curves will fall out of a CAPA model as like a byproduct. So this is really CAPA light. But it should, if you went into a CAPA model of one of these services, you should be able to fiddle around and come out with the same demand and capacity curves.
No, that's great. Thank you.
Thank you. So Lila Johansson's asked a question. And she said, presumably this may also be useful to use in combination with a patient tracking system.
Yeah, it could be, couldn't it? Because then you'd be running this through, you could run this through every week, couldn't you, on what you've seen in the last week and what's coming through next week, and constantly refresh it. Yeah, it certainly could. This will work for any waiting list and any queue, essentially, where you can define those characteristics. So my example of the post office, they'll be thinking, how long does each person spend at the counter? And you think it's probably 2 or 3 minutes, isn't it? You go and buy your TV license or something.
Perfect. So yeah, sorry.
No, that's okay. I was only waffling.
No, I didn't mean you're not waffling at all. So Gurprit's asked a question, and she said that presumably it assumes a standard bell curve as opposed to a very skewed graph.
I think it assumes a Poisson distribution, which is weighted towards the lower numbers. So if you look at the curve of the number of appointments, then it generally peaks. If you look at a pathway, all the discharged pathways last year, and you look at how many appointments they had, the peak of the curve is towards the left of the axis, not in the middle. And I think that's called a Poisson distribution. So it's not a standard normal distribution bell curve, but it's a Poisson distribution, which is slanted slightly towards the lower numbers. So if you think about your average of 6 appointments, there's probably going to be a lot of 2, 3, 4, 5, 6 appointments in there, and then a long tail. And where someone's had 10 or 12 appointments, they'll be quite influential in bringing up the average. So we'd expect the peak to be less than the average, and I think that's the curve it's using to do the modelling. Does that make sense?
Yeah. Well, I'm not sure that I should answer that. Gurprit, does that make sense to you?
Yes. Yeah. So it does make sense to me, and I was trying to think about how its application to inpatient beds, and that's exactly what we do have. Is that type of distribution you've just described? Yeah. It's very tail, and the median is sort of I don't know 10, 14 days, and the mean is about 30 days, and then a really long sort of tail at the end. So that's brilliant, very helpful.
Cool.
Thanks, Gurprit. So Gavin also has asked a question. He did have to leave. So he's asked, David, how frequently would you recommend readjusting figures and remodelling in the current context? So one of the challenges is how dynamic the situation is, particularly in terms of what services input as their referral rate. So there's a balance between preparing for potential rebound surge in demand versus not having a surplus of unused new appointments.
Yeah, I mean, you could do this every week. You could work on a sit rep, and you could be looking at look at your average referrals by week, really, and then say, well, last week we were working on an average of 7 referrals, but we actually had 7.3. So now let's model 7.3 and see what that tells us about what we need next week and the week after and the week after. You could, in practical terms, whenever you've got new information, you should remodel. So you've worked out your 6.3 attendances based on last year's completed pathways, there's no reason why, if you've got a week or two or a month or two into the new year, you could recalculate and say, actually, we weren't doing 6.3, we're doing 6.6. So actually, if we don't do something, we're going to run into a waiting list problem because we haven't got enough appointments. So you can be doing this all the time and say, whenever you've got new information, if you know that your referral rate has changed, put that change in the model. If you know that the length of the pathway is changing, then put that into the model. So yeah, you could do it. You could do it every day if you had changing information. It's really when you've got some, you're reasonably sure now that people are spending longer on the pathway than they were. And when you get to that point, then you can remodel. Or you think people might be spending longer on the pathway, you could do a couple of scenarios. What if it's an extra half an appointment on the average? What if it's an extra appointment on the average? What should we be preparing for? So yeah, you can play with it as you like, really.
Thank you. That's really helpful, David. So I'm just going to carry on up. So Chris, you've asked the question. I think that you've said that you're comfortable with the tool and the theory, but can we outline or signpost what might be some sensible assumptions to make for increased demand or a surge following COVID? So within a given CCG, ICS region, a typical pathway or service. So what we should be anticipating in increase in new referrals of approximately %. So I think that relates to Gavin's literature review, where he's done some work on potential impact of COVID in terms of children and young people's mental health. And I understand something similar is being done for adult mental health. And I can send that around with the slides after this meeting. And we are looking at doing a follow-up webinar to look in more detail. So moving on from this webinar to then look at in detail, looking at the literature, the research and what that's telling us. Is that what you're saying, Chris? Is that okay?
Yeah, I think it is. As I say, I think the model's absolutely fine for looking at kind of current or historic and comparing, but I guess what we want to do is get on the front foot as much as possible and kind of confirm what additional capacity will be required in future months, because we all know how long it takes to either get staff on board or to increase our capacity in other ways. So rather than kind of get to the end of July, look back and see that we've had an increase in referrals and now we need to do something, it's just really keen to try and get ourselves in a position whereby we have an element of confidence on what additional capacity we require and can therefore go and establish. So yeah, it sounds as though the literature review may outline some of that for CAMS, but certainly within other pathways that would be really welcome as well.
Did you want to add anything to that, David?
Yeah, I mean, the CREST tool can't help you with figuring out the size of the surge, and that that's down to people's local knowledge, and it's going to be different everywhere, isn't it? But once you've got a picture of the expected demand, then immediately you can plug that into this model and look at the sort of scale up you might need of your resources. Again, you don't always need to double your resources to deal with twice as many people. It doesn't always, the maths doesn't always quite work out like that. So it's definitely worth running scenarios through this. If it's, you can think about a maximum surge, you can think about a minimum surge, you can think about midway between the maximum and minimum, and start to give yourself a range that you're looking at. That's how I think I would be using this if I was in earnest trying to maintain a service.
Yeah, I wonder whether it would be helpful, and do let me know in the chat whether we're a team now across the Southeast for children and young people as part of the cell and supporting the system, whether if we take Gavin's literature review and then maybe work with David to look at maybe a couple of scenarios, looking at the potential impact he's said for different, so for depression, post-traumatic stress disorder, and maybe sort of give a few examples. But we are looking at running a webinar, so we will send out the literature review and the dates. So hopefully that will be helpful.
I could probably produce some of these curves and stuff to support that webinar, I guess.
Yeah, that would be really helpful. Thank you, David. Dan has asked a question. It's not CYP specific. So he said that this tool for capacity planning sounds like it would be very effective in IAPT, where we have to manage the number of clinicians available for calls and appointments. And there's always a tension between wait times and DNA. Has this tool or something like it been used for IAPT, and would this make sense to consider?
I think you could use it for managing your appointments through IAPT, and making sure that you're offering enough service there to manage your demand within the wait times, certainly. And then you could also use this to model the impact of strategies to improve a DNA rate. Absolutely. There's some stuff in IAPT, people achieving caseness and some of those measures. I'm not immediately sure we could model those out, but they probably don't need modeling out in that sense. But yeah, the sort of flow through IAPT can certainly be modeled using this, no problem at all. But some of the nuances of IAPT will be lost in this tool, and you'd have to work on those outside of it.
Thank you, David. So I'm now going to ask to see if anybody has any other questions. I think I've covered most of the chat, the questions in the chat. Are there any other questions? We've stunned you into silence. I mean, it's been a very comprehensive overview. So thank you very much, David, for your time and your introduction to the webinar. As you said, we'll send out your slides, if that's okay, afterwards, and the literature review, and we'll send out a date as soon as we have that for, you know, taking this in more detail and looking at the literature and say, well, we think there might be X percentage increase, and then how, you know, taking that on really as you're all doing your recovery and restoration plans, and we really want to be able to support that. So I think that if that's it, we can close a bit earlier. I don't know whether you have any other comments, David.
Just thank you for having me.
No, thank you. I think that some of the maths went over my head. Yes, but
several months to get to grips with the maths, and actually you don't need to. It's useful to know that there's some crazy maths in the background. But it is crazy maths, really. Unless you're a mathematician, it's baffling.
Yeah, no. Well, I'm just about learning fractions with my son and homeschooling, and he's 8, so that's bad enough. So, I mean, I just want to thank everyone for your time. You know, during this period, we have recorded this, so we will be able to circulate this with the slides. And I just want to thank David again for his time, and we will close the meeting. So thank you very much, everybody.
Bye-bye.
Thank you.